Today's objective is to explore novel therapeutic targets based on an advanced understanding of the ineffective erythropoiesis and how it governs thalassemia. And we're also going to talk about the current landscape of gene editing and gene therapy in thalassemia, very much a hot topic. When we think about thalassemia, most people often associate with anemia, but behind that anemia are two components. One is called ineffective erythropoiesis, in which the body has a very difficult time in making the blood. And the blood is not able to survive into the circulation, because even before the blood is made, inside the marrow, it takes a long time for it to develop. And then once it's developed, it then goes into the circulation. So you can think about it in two parts. The part where the red cells are developing from, you can think about it as a little baby into, maturing into an adult red cell. That part is called erythropoiesis. Ineffective erythropoiesis is when these red cells have a hard time maturing, such that they can't even go out into the circulation, into the blood vessels to do its job, to be able to deliver oxygen and nutrients to the rest of the body. Once the red cell exits the marrow, so you can think about it as, say, children graduating from high school, once they go out into the workforce, right, the 120 days or however many days they're supposed to survive, then comes the hard part. The second part is called hemolysis. When they're not able to survive, when these red cells are not able to survive, then they break down faster. And that process is called hemolysis. So for many patients, especially those with what we call thalassemia intermedia, or those who are not on transfusions, they have both ineffective erythropoiesis, not able to make the cells, but any cells that are made are defective, and as a result, they get hemolysis as well. So you get the worst of both worlds. Whereas patients who are transfusion dependent, they mostly suffer from ineffective erythropoiesis because they just can't make the cells. The cells don't even have the opportunity to survive into the circulation to be destroyed later. So why am I talking about this? Why is this important, right? And it's because right now there are many potential therapies that we can exploit this particular pathway, the ineffective erythropoiesis. And just to guide you through this map here, obviously, for beta thalassemia, we're talking about beta globin being defective or being absent. In alpha thalassemia, we're talking about alpha globin being defective or absent. And in the absence of these globins, you can imagine now there's an imbalance in terms of ratio. So it's like going to the high school prom and there's a whole bunch of kids being left out because they couldn't find a partner. And what happens is these excess globins are going to precipitate, they're going to aggregate, and these aggregates are bad. Okay, whenever they hang out, whenever excess globin hangs out, it's a bad thing. It's like a bunch of gangs, roving gangs running around, pillaging and looting inside the red cells. Okay, and it will cause problems. And the problems that they cause are the following. It will cause the red cells to die prematurely through a pathway called GDF, or growth differentiation factor, through the SMAD pathway and through GATA1. GATA1 is actually got distracted, and because GATA1 is actually the one that promotes the differentiation, promotes the growth of the developing red cell. And if GATA1 is distracted, then the red cell is not going to grow and die. In addition, iron is going to accumulate inside the red cells, and these iron are very toxic. They generate reactive oxygen species, which causes damage of the red cell membrane. In case you can't see where I am, I'm going to put on a laser pointer. This then will lead to the inability for the red cell to mature or differentiate, and hence in effective erythropoiesis. The iron pathway plays a huge role in regulating this, because obviously iron A is essential for the developing red cell, right? It's essential for making hemoglobin, but more so is that the iron itself, if there's too much of it, can be toxic, and the toxicity can kill these developing red cells. And so if we glance here, then we can see that these blue arrows represent opportunities in which we can target this particular pathway and make it work. The simplest and one of the oldest techniques that we have is called hydroxyurea. It's a compound that's well known in the circles of sickle cell disease, but it has also been tried in thalassemia. with variable success. I'd say most often not, patients do not respond to hydroxyurea in increasing the hemoglobin, but it is cheap. It is relatively easy to give. It is widely available. And so this is why in the TIF guidelines, the Thalassemia International Foundation guidelines, for the non-transfusion dependent thalassemic population, that it is still part of the armamentarium in the treatment of NTDT. Then you have other agents like thalidomide. We're going to talk about IMR 687 tonight. Sirolimus, benseroside, which I'll talk about as well. Luspatercept is one that targets the growth differentiation factor pathway. Mitapivat, which specifically targets the reduces reactive oxygen species and the red cell membrane damage. Other ones I'm going to talk about as well are the TMPRSS6 inhibitors, as well as the vemifemport, as well as SLN124. Now, why did I pick these to talk about? Is because we have new results from the American Society Hematology meeting back in December of this year. So I'll be providing you updates for that as well. Great. This is just showing in terms of development these compounds are. You can see that luspatercept is the only agent that is approved both in the USA as well as in European in the EU as well as in Canada. Mitapivat right now is in phase 3. Thalidomide will be entering phase 3. LJPC401 is a hepcidin mimetic, is currently just finished phase 2. PGD300 also finished phase 2, as well as a mini hepcidin. Ruxolitinib is a JAK2 inhibitor, finished phase 2. Other ones that I'm going to talk about tonight, the Imara one has just finished phase 1, will be entering phase 2, as well as the vemifemport, which will be entering phase 2 as well. So you can see that the race is on. That's the bottom line. You can see a lot of different compounds, a lot of different ways in which perhaps we can modify the outcome in people with thalassemia. These are the ones we'll be talking about. So let's start with luspatercept, since it is the first agent, disease-modifying agent to be approved in transfusion-dependent thalassemia. As I mentioned before, it is part of the TGF-beta superfamily that binds to the class 2 activin receptors. So the idea here is that by binding to these now, here's the thing. We don't know where exactly ACE536 or luspatercept acts on. We know that it acts on one of the growth differentiation factors, but it seems like, with most recent findings, that GDF11, certain ones that we thought initially that it worked on, it actually is not sufficient to improve an effective erythropoiesis. So there must be multiple targets that this particular drug acts on, and I quite don't know where exactly it does, but we know that it does work because I'm going to show you the data on it. In any case, so what happens is that when it binds to the class 2 activin receptors, it activates a SMAT pathway, then it causes phosphorylation, dimerization of SMAT, which then goes into the nucleus and alters the gene expression and prevents the red cell from maturing, causing ineffective erythropoiesis. And luspatercept binds to the activin inhibitor and prevents that from happening, it blocks it. In the phase 3 study, which I presented a couple of years ago, is a phase 3 randomized controlled trial called BELIEVE in transfusion-dependent thalassemic patients, where they defined the primary outcome as a transfusion reduction of greater than 33%, 21% in the luspatercept arm versus 4% in the placebo arm achieved a transfusion reduction of more than 33%. So that means it works. But if you look at the overall scheme of things, what we're really saying is that in thalassemic patients who are transfusion dependent, 1 out of 5 is going to have a reduction of more than 1/3 in their transfusion requirement. Okay, so it depends on how you look at it, right? If you look at it from a cup half full, well, we have nothing in the past. Now this is actually something. And then if you look at half cup empty, well, 1/5, 1 out of 5 patients is actually not a lot of patients. Um, then the question is, okay, so we can reduce transfusions. Can we reduce iron overload? And is it efficacious in people who are not transfusion dependent? So I shall show you those data now. So first of all, this is a graph showing that there is long-term reduction in both ferritin as well as liver iron concentration in those people who responded to the medication. You can see here in both brown and the green, and green represents patients who are the responders, and the hatch ones are the responders, and the solid bars are the overall patients. You can see that up to week 96, which is the green bar, that we have both a reduction in ferritin as well as a reduction in liver iron concentration. And then you're going to say, well, looks like in week 96, there's, in those who respond, the reduction of liver iron concentration is only 1.5. Milligram per gram dry weight. Now, if you think about it, that's not a lot, right? And certainly, if let's say if someone has a liver iron concentration of 7, going down from 7 to 5.5 is actually not that much. But you have to remember that many of these participants in the studies had already some response to the to the drug, and so I would say that this actually represents a meaningful change for these patients who do respond to the medication. And then the second question is, what about NTDT, non-transfusion dependent thalassemic patients? You can see here that in the Beyond trial that was presented recently, of the 145 non-transfusion dependent beta thalassemic patients who were randomized 2-to-1 to luspatercept versus placebo, with a primary outcome of greater than 10 grams per liter or 1 gram per deciliter of hemoglobin increase in weeks 13 to 24. So within that half a year, that 77% of patients had an increase in hemoglobin greater than 1. And interestingly enough, unlike in the BELIEVE study where there was 8 out of 200 patients having clots, in the BELIEVE in the Beyond study, there was no thromboembolic events. There was no clots. So we found that somewhat interesting, because we know that traditionally people who are non-transfusion dependent thalassemics are at very high risk of clots. Next. Okay. So the next question is, what about quality of life, right? So here I present the abstract from ASH this year, and they looked at different patient-reported outcomes. These are essentially quality of life instruments, and here I have the table of the two. You can see on the left here, we're dealing with a PRO called the NTDT PRO, and on the right-hand side, we have the FACIT-Fatigue scale, we have the SF-36. The first thing that people are going to pick up, of course, is that the p-values are not significant. And that is very true, is that, between luspatercept and placebo, there was no significant difference in terms of quality of life. But what we do notice is that there is some reduction, there's some improvement in the quality of life, as you can see here. So getting more negative in the NTDT Pro means that it's actually improving. And then same here with the FACIT-Fatigue scale, an increase in the score is actually improvement, as well as in the SF-36. But the other trend that we also see is that the improvement is sort of slightly more qualitatively, at least we can look at these numbers, and then slightly more between weeks 37 to 48 compared to just weeks 13 to 24. So at 1 year's time, there seems to be a greater reduction in quality of life. Now, in terms of whether this is a meaningful change, I'm going to leave it up to the discussion panel, because that's where we're going to have lots of fun talking about this and whether this is significant at all. So now I'm going to move on to mitapivat. As mentioned previously, the imbalanced alpha to beta globin ratio creates a precipitation of excess globins. This generates reactive oxygen species, hemichromes, which causes oxidative damage, creates hemolysis, ineffective erythropoiesis, and causes anemia as well as iron overload. the hypothesis here is that mitapivat, by increasing glycolysis and increasing ATP availability, ATP is a type of batteries. You can think about it as batteries that are being used in red cells. By increasing the amount of battery life in these red cells, we're hoping to reduce the hemichromes in reactive oxygen species, oxidative damage, hemolysis, and effective erythropoiesis, and so we can improve anemia as well as the iron overload. The preclinical data comes from transfusion-dependent HBV Th3 positive mice. And in these mice, that the Dr. Mate's group was able to show that mitapivat increased the transfusion interval from 11 days to 14 days and reduced the liver iron concentration in these mice as well. Well, it sounds like, the thalassemic mice are having a good time with this drug, so let's see how it works in humans. Well, here, I presented this last year, so in December, that shows that patients who are on this medication long-term up to 72 weeks had, not only is it a sustained response in terms of hemoglobin, you can see on the top graph here that hemoglobin increased very dramatically and very quickly within 4 weeks to at least 1 gram per deciliter, or 10 gram per liter in Canadian units. And you can see that the hemoglobin increase is sustained all the way up to week 72. And you can see that there's qualitatively, you can even see that there's a slight, slight trend upward. In terms of like who responded, now I must say that this is actually the first study aimed at both alpha and beta thalassemia. And we can see that all the alpha thalassemia patients responded in this study, in addition to 11 out of 15 beta thalassemia patients. What about markers of hemolysis and erythropoiesis? Those were also improved, showing that we are reducing the hemolysis in these patients. In terms of adverse events, initial insomnia was one of them, as well as headaches. This particular drug has what we call mild aromatase activity, and there's always a concern that it can affect bone density. But we can see here bone density actually remains stable for all the participants, and then for those who up to week 72, they also remain stable. And because of these encouraging results, there's two phase 3 randomized controlled trials, both Energize and Energize-T, that are looking at transfusion-dependent and non-transfusion-dependent thalassemic patients, respectively. Next, I'm going to go to the competitor of mitapivat, which is called etavopivat, or FT4202. It's developed by another company. It is also a pyruvate kinase activator. It's the same mechanism in mitapivat, but there is no aromatase inhibition. They are currently running a phase 2 open label study in both transfusion dependent as well as non-transfusion dependent thalassemic patients, in addition to sickle cell patients. They plan to enroll 60 patients. They plan to complete the study in March of 2025. And you can see that, again, very similar to the mitapivat study, that they're including both alpha and beta thalassemic patients. And the primary and secondary outcomes are looking at a transfusion reduction in these patients. And then for the non-transfusion dependent thalassemic, because they're not on transfusions, obviously they're looking for a hemoglobin increase. On to the next drug, IMR-687. So what is IMR-687? It is what we call PDE9 inhibitor, phosphodiesterase 9 inhibitor. What it does is that it increases a compound called cyclic GMP, okay, inside these cells, which then, inside the developing red cells, which then will increase fetal hemoglobin expression. Now, why do we want to increase fetal hemoglobin expression? Because we have to remember that in beta thalassemia patients, at least, the lack of beta globin can be compensated by making fetal globin or baby hemoglobin. And in the mice, in thalassemic mice, 18 thalassemic mice that was treated with this compound, they found that there was this significant dose-dependent increase in hemoglobin red cells, as well as reduction in reticulocyte count, as you can see here. And the average increase in hemoglobin is between 1 to 1.5 grams per deciliter. And because of and there was also a significant increase in both mature as well as a reduction in immature erythroblast population, meaning that the red cells are actually maturing. They're actually entering maturation. They're not stopping prematurely. They're not dying prematurely. And because of these encouraging results, there's now an ongoing recruitment into the phase 2b study. SLN 124 is increases hepcidin by inhibiting a gene called TMPRSS6. And in this phase 1 randomized double-blind placebo-controlled trial, that they found that hepcidin level actually increased in a dose-dependent and a time-dependent fashion. Iron also decreased in these patients. However, the question then is, well, yeah, yes, we can change the iron balance in these patients, but what about the ability to make red cells, right? Because ultimately that's what we want in thalassemia. So now they're running the Gemini 2 trial to see if the hemoglobin perhaps can increase as well using this mechanism. Next one I'm going to talk about is benserazide. It increases the half-life of L-DOPA when it's used in combination for treatment of Parkinson's disease. However, that in anemic baboons that we've shown that it can actually increase fetal hemoglobin expression. There's currently a phase 1b dose ascending study that's currently running at Toronto General Hospital. We plan to complete this study by August of 2022. We're looking at, again, changes in fetal hemoglobin, F cells, et cetera, et cetera. Apotransferin. Well, how does apotransferin work? Apotransferin actually inhibits, again, is one of those iron metabolism proteins. It inhibits transferrin 1 expression, so it decreases the transferrin's partitioning inside the developing red cells during the process when the red cell is trying to push out the nucleus. So what it does is that it will enhance, it will make the pushing out the nucleus much more effective in defective beta thalassemia red cells. And not only that, by reducing the transferrin 1, it also upregulates hepcidin as well. And currently there's a phase 2 open label trial running where the non-transfusion dependent thalassemic patients are given IV injections of infusions of these medications of the apotransferin every 2 weeks for 14 to 18 weeks. And they're looking at changes in hemoglobin, number of red cells transfused per week, etc. Another TMPRSS6 inhibitor is ISIS 702843. And in this compound, it also inhibits TMPRSS6, which then increases hepcidin expression and reduces the effective erythropoiesis. And in the phase 1 healthy volunteer studies, they've shown that there was a reduction in serum iron, transferrin saturation, as well as increase in plasma hepcidin levels. There was a small, unfortunately, in the healthy volunteers, they observed a small reduction in hemoglobin and reticulocyte hemoglobin. Now, whether that translates into the thalassemic patients is unknown at the moment. That's why they're running a phase 2a trial, because in thalassemic patients there is stress erythropoiesis going on. So the environment, if you can think about it, under which this compound is going to be working in is going to be vastly different than, say, healthy volunteers. So there may not be a decrease in hemoglobin after all. Who knows? But again, what they're looking at is a reduction in iron, but also an increase in hemoglobin in these patients. Vemifemport currently is running a phase 2a study. And again, they're also looking at increases in hemoglobin and also other iron parameters. The question then is, with all these different compounds that potentially can nudge the production of red cells in a favorable direction, what about combination therapy, right? That's, like, would combination therapy be better? Is 1 + 1 = 2? And so, again, at ASH this year, there was an abstract showing that a combination of luspatercept-like drug with a TMPRSS6 inhibitor is superior to using either drug alone in correcting beta thalassemia. So what they have done, this is like proof of concept model. They have taken mice, these are Th3 plus mice, and they treat them with this luspatercept-like drug and or the TMPRSS6 inhibitor. And they found that the combination achieved the highest increase in hemoglobin, compared to either agent used alone. And it shows that it decreases reactive oxygen species, it reduces the spleen size, reduces iron, transferrin saturation, increases the hepcidin. And not only that, only this combination has shown a reduction in ERFE and increase in erythropoietin. So if you're a thalassemic mouse, then obviously you're in luck because this combination works very well. In terms of whether it works well in humans, I think it really depends on future clinical trials. Now, as to whether such clinical trials will ever happen, again, that's subject to debate, and we can talk about that during the discussion because, two companies that are developing two separate therapies may not agree to combine forces, right? Because they may be competing against each other. Subject to debate. Okay, so let's go into gene therapy. Just as a refresher, gene therapy is where we harvest the stem cells from the patients, and we take these stem cells, we modify them, and then we put them back into the patient. But before we put them back into the patient, we have to clear house. And what we use currently is chemotherapy like busulfan or melphalan. What are the advantages of gene therapy over traditional stem cell transplant? Well, certainly there's no graft rejection because you're using your own stem cells. There's no graft versus host disease, again, because you're using your own stem cells. You don't have to worry about donor availability because you're your own donor. Things that we still have to worry about are things like transplant-related complications, infertility, and the risk in itself. Obviously, if we were to modify the hemoglobin, we would add a hemoglobin, a modified hemoglobin. We want to make sure that the way we add it is safe. So by using a virus vector, what is called an lentivirus vector, to inject this new gene into new functional hemoglobin into the stem cell, we want to make sure that this virus is replication defective. It means they can't replicate. We want to make sure it's self-inactivating, make sure that the gene that we insert is going to be protected, it's not going to be silenced. And so we want to make sure that it's also made a lot, right? So increase erythroid specific expression. So that's one way of doing it, is inserting a new globin gene into the stem cells. The other way is by inactivating a controller of the fetal hemoglobin production. Remember, fetal globin or gamma globin is a functional globin, and it can use to substitute beta globin. Now you got to keep in mind, gamma is a substitute for beta, but it's not a substitute for alpha, so it's not going to work in alpha thalassemia patients. Okay, but let's say you have beta thalassemia, then you're in luck, because what you can do is you can inactivate the BCL11A so that there's increased gamma globin expression, and you can produce fetal hemoglobin now in your developing red cells. The way we do that is that we can use these things called endonuclease, which are essentially molecular scissors. They can cut them. We can by cutting this BCL11A, it will deactivate it. And the way we recognize the BCL11A sequence is by using proteins called zinc fingers, which recognizes DNA or TALENs, or in the case of CRISPR-Cas9, it uses a guided RNA, which itself forms a template against the DNA, and it finds its sort of matching partner. And after the endonuclease cuts the DNA, then the body will go, the cell will go into action in trying to make a repair called double-stranded repair. But oftentimes these repairs are not perfect, and when it's not perfect, it actually adds a little more or deletes a little more, and when that happens, then you have a deactivated BCL11A, which is exactly what you want. So now that I talked about the techniques, I'm going to go through some of the results. In the first one I'm going to show you is the HGB-207 study. These are non-beta 0 thalassemic patients. You can see that patients have largely achieved transfusion independence, as represented by the dark blue bar here. And in terms of the transfusion independence time frame, one patient even is up to 19 months after the gene therapy. So it's the majority of patients, 10 or 11, are transfusion free at the moment. And in terms of what about iron balance, right? We can reduce the transfusion need. We can even eliminate transfusion need. And you can see here in this graph here in this most recent study that that there is a reduction in normalization, or at least trending towards normalization in the iron overload for these patients in both serum ferritin as well as in the liver iron concentration. What about quality of life? Well, we can see here that the quality of life is somewhat equivocal. You can see that, compared to patients who do not achieve transfusion independence, the quality of life has remained relatively the same. As to why that would be the case, we can again debate that in our discussion. Now let's move on to another one called zinc finger. Okay, this one is ST400. And you can see here that of the, they had 6 patients in here. There was no safety concerns here. However, the fetal hemoglobin increase is not sustained. You can see here initially the fetal hemoglobin was quite low. It peaked at 24%, but then it sort of dropped back down to 8% for the average patient. So unfortunately, fetal hemoglobin using this method wasn't sustained, and patients did not achieve transfusion independence. CRISPR didn't have any new publications this year, but previous studies with the CRISPR with the 5 patients, these are 1, 2, 3, 4, 5. You can see here, most of the patients were able to achieve some form of transfusion independence, as evidenced by the first, second, third, and the 4th patient. This patient did not achieve transfusion independence. So what are current limitations of gene therapy in thalassemia patients? There's a risk of relapse, right, as been shown in the ST400 study. Age is a limitation, although morbidity does increase with age, although that's sort of breaking the barriers now, has been increasing from 25 to 35 and probably go beyond that in the future. Infertility is still a concern for these patients, and of course potential secondary malignancies, because we are using some form of chemotherapy. There has been 2 cases of acute myelogenous leukemia in 2 sickle cell patients who have received the BB0305. That's a lentivirus globin vector in sickle cell disease. Now, this hasn't happened in thalassemia, thankfully, but any of the thalassemia trials. But this is something that we're watching very, very closely. Then the question is, how do we mitigate these potential risks, right? Because we talk about the potential of failure to engraft, immunogenicity, maybe integrating, maybe these new vectors are going to integrate themselves into places that they shouldn't be in, or that is going to interrupt important cellular function, or causing transformation into cancer. So to mitigate this, FDA has mandated 15-year follow-up for any patients who join a gene therapy study. These patients are surveilled very closely for cancer, as well as looking at the bone marrow and the peripheral blood for what we call off-target editing. Lastly, I want to say that we need an international effort to discover new targets, and the reason is because there's still gaps in understanding of ineffective erythropoiesis and hemolysis, and you can see that a lot of the potential targets that we have, or potential therapies, are aimed at beta thalassemia, whereas alpha thalassemia is still relatively neglected. So thankfully now there's an international consortium looking at a large-scale multi-ethnic genome-wide association studies with 168 experts from 89 organizations in 36 countries, of which Canada is one of the participants. We're looking to recruit up to 30,000 patients across the globe to conduct this study. So in conclusion, advances in our understanding of ineffective erythropoiesis in thalassemia has enabled us to develop very new therapies. I think we should give consideration into combination therapies, because it seems to work, at least in the thalassemic mice. I think there's still lots of gaps in terms of understanding in terms of how thalassemia works, especially in alpha thalassemia. Gene therapy is pretty attractive, but we need to weigh against these potential and theoretical risks. And remember, gene editing is currently largely confined to beta thalassemia patients. So we still have a lot of alpha thalassemia patients who are being neglected. And international collaborations such as Inherent that I've just shown you, into where we're going to engage in discovery of genetic modifiers, probably is going to yield even newer or even better targets. We can create risk scores to see who is at risk of iron overload, who is at risk of developing severe anemia. We can use it to prognosticate, right? We can say who's going to respond to therapy A versus therapy B, because as we have seen with luspatercept, not everybody is going to respond to the medication, and we can't just simply put everybody on the medication and then hope for the best. So something like this may tell us, maybe person should get this drug or the other person should get the other type of drug. And this way we can create individualized treatment approach. And with that, I thank you for your attention, and I'll hand it back to our moderators.
Okay, thank you very much, Dr. Ko. So now, before we invite questions from the audience, I am going to call on Uzma, and I'd like to introduce Uzma and invite her to share some experiences. Uzma was born and raised in Edmonton, Alberta, and currently resides in Toronto, where she works as a freelance copy editor, writer, and independent bookseller. She was diagnosed with beta thalassemia as a toddler and has dealt with many challenges in the management and treatment of her condition. And she credits the advancements and access to them that have been made over the course of her life for being instrumental in her ability to pursue her goals, as well as her overall physical well-being. She is a proponent of patient advocacy and believes that patients should educate themselves so that they may be better equipped to make decisions regarding their care and treatment, rather than allowing for a one-size-fits-all approach. She is excited about the new therapies being presented today and looks forward to seeing what the future holds for patients with hemoglobinopathies. So, Uzma, I invite you to join us. Hi there.
Hi. Hello, everyone. My name is Uzma. Josie, thank you so much for that lovely introduction. And thank you, Dr. Ko, for giving us a very, very thorough overview of what is happening currently in the research field of therapies for hemoglobinopathies. So as Josie mentioned, I have had some challenges when it comes to treatment and management with thalassemia. I grew up in the 80s in an area that was not very well versed in hemoglobinopathy in populations. I grew up in Edmonton. It's in the 80s, it was a very homogenous population. There weren't a lot of people with thalassemia, sickle cell, and other more quote unquote foreign conditions. So growing up, I unfortunately didn't have access to chelators and drugs that other populations were able to access. So I think it's really important that we do advocate for access for a wider population. I've been really lucky since I was young to be able to take part in a number of studies. The first one was for XJ, which was, oh God, 20 years ago at this point, I would say, as a alternative to Desferal for people who either were having trouble with the Desferal or were finding that it was no longer working for them. So I was really lucky to be involved in that study. And then fast forward 20 years, I have been part of the BELIEVE study, which was the luspatercept, now known as Reblozyl study. I've been lucky. I started on the placebo and was very disenchanted when things were not progressing the way I wanted. But once the open label study started and I was able to get the drug, within 6 to 8 months, we were noticing a definite increase in hemoglobin lifespan and a decrease in transfusions for me. So I went from having to get 2 to 3 units of red blood cells every 3 weeks to now 1 to 2 1 to 2 units of red blood cells every 6 weeks. So that is almost like half, which is great. I think it's an incredible result for me personally, but just generally, if this therapy is able to work for more patients, and that's the result you're seeing, I think it's a great, prognosis for patients with various hemoglobinopathies that are transfusion dependent. The other thing that I think is really important with long-term therapies like this is that when you're transfusion dependent, it's not just, like having to go to the hospital and getting red blood cells and getting transfused. You also have to think about your iron chelation drugs. You have to also think about like the impact that the number of transfusions and the drugs that you're on are going to have on your organs. This includes your heart, your liver, your veins. So I look at therapies like this in 2 parts. One, yes, it decreases the amount of transfusions, which is great, but long-term, it also helps take load off of your heart in terms of the amount of transfusions that you're getting, your liver, especially if you're on a chelator. That's something that, your XJs and your JNUs are going to go through that process, and they're going to have an effect on your liver as well. So it's not just about, being able to take these, have access to these drugs and be able to take them so that you can, decrease the amount of blood transfusions you get or units you get, but also the long-term longevity of your organs and your lifespan. I know a lot of people have trouble with, especially Reblozyl, because it is an injection. And there is a sense of it's painful and it's inconvenient because you have to go into the hospital. There's a lot of blood work involved. But again, I point to the long-term, like it's a short-term discomfort for a long-term goal that will, better your quality of life, in my opinion. And I think that's really important to understand as a patient. I always say that, like, don't look at the picture right in front of you. Look at the picture that's, like, what do you want to see? Where do you want to see yourself in 5 years? Where do you want to see yourself in 10 years? Do you want to travel? Do you want to have children? Do you want to have a family? What are your life goals? And how is thalassemia, or how is your specific condition going to affect your ability to achieve those? And as Josie mentioned in my bio, I've been really lucky. I have been able to go abroad and still be able to get treatment and still be able to, survive and function and thrive, because I've been so adamant about, okay, this is what's important to me. This is what I want to do. How can I get there? What do I have to do to make sure that I will thrive in this situation and, be able to do the things that I want to do? And this is where I say, like, patient advocacy and educating yourself about different, whether it's a therapy, whether it's, diet, whether it's what's available elsewhere. You really need to, you can't expect your healthcare providers to be on top of everything. They have lots of patients, they have lots going on. If there is something that you see or hear about, or, are interested in or have concerns about, like, do a little bit of research, bring it up with your healthcare professionals. And, therapy and treatment and management, it's not one size fits all, and it can't be, because everyone has a different, medical background. Everyone has a different healthcare situations. I'm lucky I don't have diabetes, but there are thalassemia patients that do have diabetes that have to deal with other things. I have, hormone issues that I have to deal with as part of my thalassemia diagnosis. So that's something that maybe somebody else doesn't have to deal with. So I think it's really important for patients to really, do their own homework and work with their healthcare providers to come up with a plan that works for them. yeah, I don't think I have anything else.
Thank you so much. Thank you very much. And you'll be hanging on, I think, for part of the discussion as well, right? So thank you very much, Uzma. Now we're going to go into, I'd like to introduce the rest of the panelists, and we are moving into the discussion and Q&A with our experts. I've already introduced Dr. Ko, so Dr. Ko will be staying on and helping to answer questions. But I'd also like to invite Dr. Yves Pastor, who is Professeur agrégé de clinique at Saint-Justin Hospital. He is in the pediatric hematology service. So he is a pediatric hematologist of Swiss origin. He trained in Texas at the Children's Hospital there. And we were very fortunate that he came north to now practice at Saint-Justin in Montreal since 2010, where he is one of the leading physicians for the hemoglobinopathy and cytopenia programs. He also has been chair of the Canadian Hemoglobinopathy Association. So bienvenue, Dr. Pastor. And I would also like to invite Dr. Ziad Sol, who is a hematologist and transfusion medicine specialist at London Health Sciences Centre, and he is an assistant professor at Western University. He received his doctorate in medicine from the University of Ottawa and his hematology training at McMaster University. He then completed a clinical investigator program and a Master of Science degree in health research methodology at MAC, followed by transfusion medicine fellowship at Canadian Blood Services. So he currently directs the Adult Red Cell Disorders Hematology Clinic at London Health Sciences Centre, where he sees patients with sickle cell disease and thalassemia. And he is head of the transfusion medicine division in the laboratory. So welcome to all of you. So I will start off with a few questions, and I do invite people to also add to the chat. And I am not sure if another board director, Shirin, might be helping me with that.
Yeah, I'm keeping track of the chat. Yeah, I got it.
Great. So I've got two screens going here, and so I am very much present, but looking to my notes here at the other side. But I will start off with a question that we did receive ahead of time. And it does pertain to, yes.
Josie, sorry, let's have the doctors talk for a couple minutes about their work at their clinics and if there's any research or clinical trials that are going on.
Perfect. Thank you, Riyadh. So I will invite Dr. Pastor to start.
Right. So, you know, and I see a significant number of patients with hemoglobinopathy, but those are mostly sickle cell disease, and that reflects the number of patients that we do have in our clinic. We have some patients with thalassemia, but in Montreal area, those are really much fewer than the number of sickle cell patients that we do have. And that there might be variations across the country. So we do follow also a lot of other patients with red cell disorders or genetic inabilities to make new red cells, such as black van Dam anemia. And we're confronted in the problems of patients requiring chronic blood transfusion. So we do participate in some studies, but given the number of patients, you know, those studies tend to address mostly patients with sickle cell disease. We are in a process of trying to open studies with the equivalent of the etapivir drug at our center, which hopefully will be at some point able to also recruit patients with thalassemia. So we do participate in research. The other thing is maybe something that Kevin didn't mention, but we're certainly aware that stem cell transplantation is also a curative approach. So beyond gene therapy, it's something that we also do at our centers. We are one of the referring centers for bone marrow transplantations for Quebec. And we do have some experience in transplanting patients with thalassemia. And this is mostly interesting if you have a matched sibling donor, of course, that do not have thalassemia major, but that is also an interesting approach that is worth mentioning, where we do also have a lot of experience.
All right. Merci, Dr. Pastor. I'll now throw it to Dr. Sol.
Yeah, thanks for the introduction and for having me. Yeah, so I work at the London Health Sciences Centre in Southwestern Ontario, and we really opened the clinic just a few years ago in 2017 as a comprehensive care clinic. Before that, it wasn't really much of a comprehensive care clinic, meaning that we didn't have a social worker, we didn't have a proper nurse. So, you know, it's been a really nice addition to the region here. And we, like everybody else, we see more sickle cell disease than thalassemia. But our thalassemia numbers are kind of climbing regularly, and we don't have any trials at this time, mainly because we're focusing on our clinical operations, making sure they're as great as possible. And yeah, you know, community is very small, so we know Dr. Kuo very well. If there are research studies opening elsewhere, we make sure to connect. And you know, Uzma's story was very reminiscent of all of our patients who you know, are really trying to find the best option for them. And it was really nice to hear Uzma's perspective, for sure.
Thank you, Dr. Sol. Dr. Kuo, I'm going to invite you to see if there was anything you want to say specifically about the clinic at UHN.
I think the philosophy which I'm trying to conduct our clinical work is that because there's no disease-modifying treatment, at least not until recently with luspatercept, there's no disease-modifying treatment or curative treatment for thalassemia. My goal has always been to provide as many options to our patients as possible, and this is why I've been working on bringing all sorts of study to our clinic. The way I see clinical trials is no different than, say, what we call standard of care, because ultimately, if you look at a standard of care, it's rather pitiful, right? I mean, transfusion, chelation, I mean, this is not sustainable. No one would ever argue that that is a sound and logical approach in the treatment of thalassemia. And so whenever there is a clinical trial opportunity, I always bring it in. Of all the compounds I've listed tonight, we are participating in most of them. You know, we're continuing on the luspatercept study, bensericide. We're participating in some of the TMPRSS6 inhibitor trials. Certainly the mitapivat study, even its competitor etovapivat. So we're agnostic. You know, I just want to say we don't favor any one particular company, come one, come all, right? So that patients have a choice, because ultimately that's what I want my patients to have, is that choice to choose. Because not having a choice sucks. I know it because I have a daughter with, you know, chronic diseases, and trust me, we want choices. So yeah, that's and of course gene therapy as well. I'm bringing in trying to bring in a lot of gene therapy studies.
Okay, all right, thank you very much. Okay, so this brings us right just about on time, if I had my glasses on, to our Q&A now. So so we invite you to put up your hand and ask a question, or put it in the chat. So I am going to throw it to Shirin first for the first question, and then we'll go to the raised hand.
Sure. So Josephine had asked, question for Dr. Kuo. mRNA vaccines are promoted as a cut and paste technology that can inject protein producing code into the body, example, spike protein. Is it possible to create an mRNA vaccine, quote, vaccine that can allow beta globin protein to be produced so that the beta thal patients can simply receive, quote, booster shots instead of transfusions? It's probably not that simple, but something I've been wondering. Thank you for this call. And Dr. Ko had responded in the chat. He had said, hi, Josephine, that is an excellent idea, but my feeling is that the mRNA may be too transient in stem cells to sustain globin production. There is a phase 1/2 trial of mRNA vaccines in methylmalonic acidemia and inborn error of metabolism. So who knows, maybe with a little tweaking, it will work in thalassemia. Dr. Ko, do you want to elaborate on that?
Sure, yeah. So the idea about mRNA, these are messenger RNAs, okay? And these are not meant to live forever, unlike the DNA that are meant to be produced and replicated from cell to cell to cell, so that you can think about DNA as like the hard disk, right, for storage of information, whereas mRNA is like the random access memory, or the RAM inside your computer. As soon as you turn off your computer, it's gone. And so that's the idea. The reason why it works in vaccines is because the mRNA enters a dendritic cell, which then will present the protein that's made of the mRNA, and then by recognizing that protein, you can actually make lots of antibodies, which are like missiles, and those memory are long-lived in our immune system. So that's the good thing about our immune system. It's like an elephant. It remembers things from a long time ago. The problem with stem cells is that it always likes to grow, it always likes to differentiate. So it's never going to remember anything. And then if the mRNA degrades, then it's just gone. I think I envision what we can do is that we can start adding caps to the mRNA so as to stabilize the construct so that it doesn't degrade as fast, it doesn't get chewed up. So perhaps that's a possibility. I mean, we do know that there's actually a number of phase 1/2 trials, as I mentioned, the methylmalonic acidemia, which is a type of inborn error in metabolism. There's also a number of mRNA vaccines that are directed against cancers. So we know that there are these trials out there that are trying to target non-infectious diseases, but I think it's still in its infancy. Perhaps, with changing technology, we will be able to achieve something.
Thank you very much.
Thanks, Dr. Ko. We do have another question from
All right, go ahead.
Sahresh. She said, I would like to know what side effects the patients have for being on Desferal infusions for long term. My son is on Desferal for a year because Exjade makes his liver enzymes rise.
Okay. Would Dr. Pastor, would you like to take that question to start?
Yeah, so Ziad or Kevin, you could also comment on the long-term Desferal usability. So there are a couple of things that you might want to follow. Just make sure that you don't have some toxicities of the drug. One of the particular point with Desferal is that you cannot not usually bring the iron stores level too low because there might be some side effects, particle on their hearing. But overall, it's fairly well tolerated, right? Ziad, I don't know how your experience, and Kevin, you might have also a greater experience with the long-term use of Desferal in adults.
Yeah, it's definitely dependent patient to patient. So we do a lot of screening to make sure that side effects are checked very regularly. The main thing will be kidney function and making sure that, as Eve said, if the ferritin drops too low, that's when the iron chelator medication can start attacking healthy tissue. So hearing loss, more kidney dysfunction, even liver, and it can cause, obviously there's always a long list of things, but if you stay, seeing your hematologist very regularly, they're gonna make sure that these toxicities aren't going to happen. There's protocols for following these things and annual hearing tests, etc. And a lot of the side effects are similar with other chelators, not just Desferal. So the other options are going to have their own set of side effects that we just kind of modify our monitoring a little bit more. So there's no perfect answer. Like Kevin said, we want more options. And then finally, we have dual chelation. Sometimes our patients need more than one chelator, and then now we're juggling two sets of side effects. And I think the best patients we have are the ones that are coming to all their appointments and making sure that we are monitoring everything. the patients I worry the most about are the ones that either are not able to come to their appointments because of life, or because of they may not have the enough guidance at home from family members to support them to actually come to the hospital. So I think the main message is hopefully follow the monitoring guidelines that the doctors are stressing so much about every time you go to the clinic.
And the balance, of course, is that they just always think the reason why we give those medication. The tricky part of this for all is that it can be very challenging and it's quite demanding of using desferal. But what we have to look for is that we're fighting iron overload, and if you don't treat that correctly, the long-term risk of it are much greater than the potential side effects of the medications. So it's quite a tricky balance. I would like to highlight also what Kevin said in his presentation. What I think is also the quite exciting part today is that even though we do still have quite limited options in the treatment and the care for thalassemia patients, those options are getting broader and broader. And you see that it's quite amazing to see the number of drugs that are coming out on the market and getting on studies. And that really brings a lot of hope of the the numerous possibilities that we might have in a quite close future. For example, all the target of the TMPRSS6 modulation, of the hepcidin modulation, those will certainly help, I bet, the iron overload part, because with those agents, you're going to target the iron metabolism, decrease the accumulation of iron, and probably, I bet that we're going to see some combination of treatment, even if that, that part of studies will take some time to develop. I bet this will come and be very helpful in the management of thalassemia patients.
Can I just, sorry.
Oh, I was about to say, Uzma, you should say something, because I want to acknowledge your experience of it. I think what you've written was spot on. Go for it.
Okay, so I did write in the chat that I was on desferal for pretty sure close to 2 decades. I'm like, I'm getting old, so probably close to there. And in all honesty, like the side effects for me, comparatively speaking, I mean, as a child, they were terrible. When you're a kid, everything is awful. There was itching and swelling at the injection sites. I still have scars, unfortunately, but the bigger ones for me, especially as a young adult, were muscle aches and pains. And I did end up with some pituitary issues that were due to the overload over the chelation itself. But I will say to Suresh, I know that you're saying that you're having trouble with the desferal infusions because the iron levels are not decreasing. And this is something that I also always was concerned about when I was younger. I'd always see the ferritin increasing, but I think you also have to keep in mind that with ferritin, it's not really the greatest indicator. You do need to do your ferrous scans, and you do need to do the MRIs to actually see whether that iron is being deposited into the organs of your child. And also, there are other, XJade isn't working, but perhaps Jade New or Deferiprone. There are other therapies, and Dr. Ko and Dr. Pastor and Dr. Hood has talked about this, where you can do co-therapies. You don't necessarily just have to stick with desferal. You could do a double therapy if that will help bring down the ferritin level. So I think it's really important to have these discussions with whoever your pediatrician is, whoever your pediatric hematologist is, and ask them, say, these are other options that I've heard about. Have you heard about them? If you haven't heard about them, are there colleagues that you can speak to in different programs across the globe where they might have a better indicator of what these therapies will bring for your child? Because, it's absolutely imperative that with iron overload, one, that you consistently take your medication, whichever therapy you decide to go on. And two, consistently, keep updated on with your healthcare providers and your own research as to what's going on and what would work for your child, because it's really, really important. I cannot stress enough that iron overload to me is one of the biggest issues when it comes to thalassemia, because that is something that in the long term, like, your liver could shut down. Your heart could be so overloaded with iron that it's not going to do what it needs to do. So those are big issues.
Thank you. Thank you very much. I'm going to go to one question that was sent in advance, and then I will get to you, Kevin, I promise. So the first question I have here is, will lower toxicity gene therapy or gene editing trials take place? So I'll direct that, I guess, first to Dr. Ko.
Yes, in fact, I think Sharni raises a similar question. I'm going to read this. Can you discuss less toxic preparation prior to gene therapy? Several companies have received IND to begin using monoclonal antibodies, i.e. anti-CD117, to transiently deplete red blood cell producing cells. Magenta Therapeutics and Jasper Therapeutics are conducting trials where these therapies in BNT. Yes, so it's true. So this is what we call immunoablation, right? Immunoablation has always been the holy grail of both stem cell therapy as well as gene therapy. In fact, this has been pursued. This idea has its genesis almost like 30, 40 years ago, ever since we understand molecular genetics and immunobiology as it is today. People have been thinking about this idea. The problem with this idea, though, is that, you're going to have chimerism, meaning that even however well you can ablate, now who knows about the future, right? No one can predict the future, but as of now, no matter how well you can ablate, there's still endogenous stem cells present. Because remember, these stem cells, right, in your body right now in thalassemic patients are not defective. They are only defective as so far as in producing the hemoglobin, but the machinery itself, in terms of cell renewal, in terms of cell replication and division and differentiation, are all intact. These are not leukemia cells. These are not people with lymphoma, that sort of thing, right? So to ablate the marrow completely using just immunotherapy is going to be extremely difficult. And with chimerism, you're going to eventually have dominance of your endogenous, your own red cell, your own stem cells are going to take over, and the gene therapy is going to fail. Look at ST400, right? I presented tonight. Initial excellent response, up to even 30% fetal hemoglobin, and now the patients are dropping down to 8% fetal hemoglobin, which is like nothing, right? So they're back to square one. And remember, these trials these are like, and that's not even with immunoablation. That's with using traditional therapies of myeloablation with busulfan or that sort of thing. So melphalan. So I mean, I'm optimistic. I'm hopeful, but I think we need to be not to be too over optimistic about this approach.
Okay. Dr. Pastor, were you going to add something?
No, I think I really perfectly agree with what Dr. Kuo said, and so and I certainly share the optimism, but I tend to be a bit cautious about those approaches. And I'm optimistic that we'll learn more on how better do the things. How to optimize the conditioning regimen that still is necessary. Are we going to reach one day where we'll be able to overcome those conditioning regimen, and certainly and hopefully avoid myeloablative conditioning? So with the use of chemotherapy agents like busulfan, that's really the hope. But we're not totally there yet. And the other thing is really to better learn on how to insert the genes and work with that, hoping that we can avoid the long-term potential risk of those approaches. And that's where I get a bit more prudent about those approaches. We're still in the learning curve. There are really a lot of encouraging results, but yeah, we tend to be kind of prudent about this. Getting back to what I was saying earlier, we in parallel to what is being done on gene therapy, we learn more and more on how to do stem cell transplant. And those both approach combined will give us a lot of information on how to do better in the future. So, non-myeloablative conditioning, which means try to lower the dose of the type of chemotherapy agent that we give in preparation for stem cell transplantation, is something that we learn more and more. And I think we're getting more and more efficient. There are still a lot of questions in terms of the mid and the long-term effect, right? What's going to happen 10 years, 20 years down the road of a person that has received stem cell transplantation? I think we still have, on that part, we do have pretty good experience, because the transplantation has been done for quite some time now. So we have a pretty good idea of what might happen, but we still have to get better on how to do it and try to lower the myeloablative conditioning. That's one part. In terms of gene therapy, there's still this big question mark. What's going to happen 10 years, 20 years down the road? That's also another part where I got a bit prudent, right? So I'm optimistic about those approaches, but I think we need to use them to be prudent about those.
Okay, thank you very much. And I promised Kevin, but I did message him that I was going to throw out one more gene therapy question before I threw it to him. And so here we are. Are there any options to replace current chemotherapy conditioning prior to gene therapy with monoclonal antibodies? So it's a very specific thing about the monoclonal antibodies, such as Magenta Therapeutics or Jasper Therapeutics products.
Yeah, so we covered that in the previous question.
Sorry. I have a 13-year-old trying to get onto a video game here. Okay, so Kevin, you've been waiting patiently. Thank you very much, and you can go ahead now.
Thanks very much, Josie. I just joined this Zoom event meeting rather late, 45 minutes into it, and I think Uzma was talking specifically about the innovative therapy that is the drug Reblozyl, Luspacer, about her personal experience with it, and that I wanted to direct a question to Dr. Kuo regarding, obviously this is something that's probably been given to treat patients around the world now for, I would say, 4, 5, maybe 6 years ongoing. It's just only been approved by Health Canada in the last little while. I have a very, I hope it's a good question or an interesting question regarding some of the, one of the effects of the drug, specifically a side effect. Could it potentially, I don't know, you could grab this answer in the short term, or is it a long-term thing? Because this is something that'll be going on for a very long time, to look at patients and the interactions with the drug. Would it actually age people, patients taking it? We know it obviously matures the red blood cells, but would the aging process speed up in someone if you were to take something like this? I hope that's not a ridiculous question to ask. I don't know if you even have the answer at this point.
Yeah.
Were you looking at that before?
Yeah, so thank you for the question, Kevin. So it doesn't cause aging of the red cells. What it does is that initially in thalassemic, as we talk about in thalassemia, because there's an imbalance between alpha and beta globin, the excess globin is going to cause precipitation and damage to the developing red cell. And these developing red cells will then go through a quality check called GDF. Okay, so imagine GDFs are like the quality checkers, the QCers that are making your Apple phone. Okay. And then they see defective Apple phones. What they're going to do is that they're not going to sell a defective Apple phone to you, right? So they're just going to throw it away. That's essentially what's happening to these developing red cells. They're being blocked from entering into circulation. You can imagine now that these QCers are very stringent, right? Any little defect in the iPhone is going to get thrown out, even a little chip maybe. But do you really care about, say, a little chip on your iPhone? I mean, you're still going to use your iPhone, right? Even if there's a little chip, right? As long as it works, it's great. So that's the idea. the drug now loosens that QC process, loosens the quality check process. So that allows even those cells with a little defect to go into circulation and serve the greater good of delivering oxygen to your body. So it doesn't age the red cells. And then it also works on a very specific target called GDF, such that it's not involved in aging at all. Aging has to do with a piece of your DNA called telomeres, Telomeres. Okay, so you should go look that up, Kevin, because that's going to give you the answer to life.
Thank you, Dr. Kuo.
Thank you very much. All right, so we do have some more questions here. So here's a question going back to the basics of treatment and blood transfusion. Has red blood cell exchange been done in Canada to reduce iron overload along with the the required chelation?
So I'm going to jump in, I guess. Dr. Bruce Ritchie from Alberta was actually one of the pioneers in doing red cell exchange in thalassemia patients, although he sort of applied it rather broadly, I would say. It is certainly against the paradigm. When he first started, it was against the paradigm of the treatment in thalassemia. I think that red cell exchange is only applicable in certain cases. And what I mean by certain cases, we have to remember that there's two pathways, right, for thalassemia. Ineffective erythropoiesis, which means you're not making the red cells, and then the hemolysis, which means the red cells that comes out are going to die or break down very quickly. When I say quick, in 20 days, we're dealing with 5 to 10 days or even 20 days here. Okay, so very short. Now, obviously, red cell exchange is only going to work in cases where the red cells make it out of the circulation but are broken down prematurely. So what are these cases? Patients with, say, alpha thalassemia major, where they produce these red cells that are filled with these defective proteins called hemoglobin bonds. So in those cases, Dr. Ritchie was actually a pioneer at doing exchange transfusions for those patients. And we have adopted that technique since at both Hospital for Sick Children as well as at Toronto General. But is it going to work in patients with beta thalassemia, especially beta thalassemia major? Certainly not, right? Because in patients with beta thalassemia major, red cells are not even produced to begin with because of the ineffective erythropoiesis. There's just no hemolysis because there's nothing being produced. So in those cases, I don't think it's going to work.
Okay, thank you. Dr. Saul, I saw that you had your prep to answer or add to it. Do you have something else to contribute?
I was simply going to say that with thalassemia, just what Kevin said, that the problem is the production of hemoglobin. It's a quantity of hemoglobin. So an exchange would work. Sorry, my daughter keeps calling. So an exchange would work best in a situation where the hemoglobin production is normal, but it's a defective hemoglobin we want to exchange with something else. Like sickle cell disease. So I know where the question is going. It's thinking about reducing that iron overload that's happening, which would be nice. But just the science it's not as applicable in that case. And similarly, why hydroxyurea may not be perfect either for thalassemia, for all types of thalassemia, only in certain kinds.
Okay, thank you very much. All right. So here we are. I have a few more questions here. We presently have 3 main chelators available as a treatment option for iron overload, and all of them have high levels of toxicity, although they are different, and have negative impacts as well as those positive ones we've heard about. And so the questioner would like to know if there are any other new iron chelators in the pipeline that take into consideration the pros and cons of the 3 existing chelators to make it the perfect iron chelator.
So we have ran a couple of clinical trials in the past with desferritin and another one called SP420. I'm currently trying to bring SP420 back into Canada for another clinical trial because I think we might have figured out the pharmacokinetics there in that if we take it every other day, it may be safer. The problem with getting new chelators in for clinical trial is that not many people are comfortable in trying out a new chelator when especially when there's other disease modifying therapies available now. And if we don't have enough people participating in clinical trial, then we won't be able to take the drug and continue to develop the drug. So it's a relatively difficult process. But I mean, if you're really interested in joining a new iron chelator therapy trial, just let me know. Another thing I'm trying as well is using non-chelator methods to reduce the iron overload. I used amlodipine in the past with some success. Again, I had difficulty recruiting patients, but I'm using taurine right now because taurine in mice and thalassemic mice has been shown to reduce iron overload in both the heart and the liver. So I actually have a trial just started actually. I call it TICATS, but it's using taurine to reduce iron overload as an adjunct to chelators.
Dr. Kuo, I mentioned earlier that I'm in Ottawa, and can you, I don't know if you could share in the chat how patients could find out about the trials that are happening or about to happen, because I'm sure by now your Toronto patients have been signed up for just about anything that is possible, if they so chose. And so, 400 kilometers down the highway, trucks notwithstanding, we would love some of that opportunity. And I'm sure there might be some other Canadians on the call who haven't been finding out about trials proactively.
I want to hand this question to Eve because
Okay.
Dr. Pastor is a CanHEM, one of the CanHEM chairs.
Yeah,
Thank you.
I mean, I'm not sure I would have the specific answers for thalassemia, but I think it's more general. It's more a general approach, and I think that maybe I'll throw the ball back to you, and you might understand why I'm saying this. I think so. First, how can we know when there is a trial open? One easy way to look at it is just to go at the clinicaltrial.gov site. If you look at clinicaltrial.gov website, which is actually a US-based website, you can look at all clinical trials that are open specifically per disease. So if you go on that site, you type thalassemia, you can look at where studies are, which studies are open, and if those studies by studies, if they are open at any Canadian site. So that's one way to look at it. So that's kind of a bit cumbersome. I'm really hoping and try to work hard to improve the sharing informations between our centers so that we know each other's, which centers do have an open study, so that patients may be referred. And that's where I throw the ball back to you. I think we still do have one problem in Canada, is how we can allow patients to travel from one province to another one if there is a study open to participate in that study. Our colleagues working in oncology are working extremely hard to make that possible. But I think it is also, it belongs to us that cares for patients with non-malignant disorders and with very severe disease such as thalassemia to fight and make sure that there is a process that makes it feasible for patients to reach open studies if they feel they need to try new medications, right? And that's one way to ensure that we'll have more options, not only for patients at certain areas in Canada, but throughout Canada. And I think there is a lot of work to do in terms of advocacy and ensuring that we have a better access to new therapies really across the country, right? Really, and really want to applaud an incredible job, Kevin, that you're doing And thanks to you and other people like you, I think we're making incredible progresses in Canada and having the possibility to get all those new therapies. But we still have to work harder, right? The other thing is also, we need to challenge Health Canada through patient advocates to ensure that access to new therapies gets a bit faster. It takes an incredible time when a new therapy is being approved by the EMA in European countries or at the FDA. In contrast to Canada, it takes a huge amount of time. And I think it's a bit outrageous to see that our patients are waiting so long to be able to get access to new therapies, right? So as physician, when we know that there's new therapies, fortunately enough, a lot of drug companies have a process in place to help get access to new therapies. So that way we can help you with this, to get access to new therapies. It's a bit hard, but it's feasible, right? But I think that, all patients advocates group needs to push Health Canada to do better, right? And that's, so, ball to you. And, if there anything we can do to help, and if you want to, raise documents in terms of, increasing advocacy alongside with other patient advocates, we'll be here with you, right? And we'll be really happy to push that with you.
So I will throw to Riyadh just in case his
Yeah,
hand
I
up
just put
is
my
in
hand
reference
up.
to this.
I want to basically go back to question of why can't patient access trials through different centers? And I want to go back to a few years, maybe many years ago, when there was a stronger collaboration among the centers across Canada, where there was even a clinical research registry, which was part of the US funded registry from the NIH, the TCR and Thalassemia Centers Registry Research Network Registry. I don't know what has happened to that. Why can't we do a Canadian-made similar registry or similar concept? Because the collaboration, yes, I know the money, but a lot of these—
Show me the money, Riyadh.
But these researchers are funded by very rich corporations that if we come up as patient organizations collaborating with the organizations like CanHEM, which I'm afraid to say lately they've been focused a lot on sickle cell and thalassemia is on the back burner, but which really is very heartbreaking to see. But we need to collaborate stronger, and that's what we push for. That's why we try to do events like this, to have dialogues, to have discussions, to let the patients be aware. We're trying to engage doctors from out west, and sometimes the time difference or whatever reasons, it doesn't work. And I'm glad that Dr. Pastor is with us because he's representing, Quebec. We have, doctors from Ontario. We are trying to collaborate, but at the end of the day, the patients are the patients, and we are the ones who are having to struggle with all of that. I'm very thankful for the parents of the patients who really push for a lot of things many times. Now we're on our own. We're trying to push for things as well. I really want to call for a stronger collaboration, and we need the medical expertise to say this is what needs to be done, this is what needs to happen, and we're really happy to take it to the governments, to the decision makers, and say that's where we need you to spend your money. Because we go to the governments and at the end they say, well, we need to look at this, blah blah blah, but if we present the solution rather than just identifying the problem, I think that will give us a big advantage and put us halfway there. In terms of access to the drugs, me being on the board of Canadian Association for Rare Disorders for the last 6 years plus, I know how it is challenging for rare diseases in general. And that's no difference for thalassemia and sickle cell as well. And I collaborate with the sickle cell on many things that we know governments don't want to spend the money on rare diseases because they are expensive. We try not to call them expensive drugs, but they are expensive drugs and they cost a lot. But we have to have a mechanism as a Canadian society, as a nation, country-wise, wide, and have a program that will cover all these. At the same time, provincial jurisdiction, that's where sometimes, things fall apart. And you have some provinces that can't fund these drugs. So the struggle is huge. It shouldn't be really burdened by the patient, but we are happy to move it forward. It just needs with stronger collaboration. We need the expertise to say to the governments, this is what needs to happen. I know you can't go and ask your governments because it's going to be put you into conflict, but we find ourselves a lot of the time we're stuck between hospital administration and governments and providers, who are like the payers for these drugs.
And so, I am going to throw out just a pitch to the 4 pages of participants that Thalassemia Foundation is always looking for additional volunteers. Many hands make light work. So we have a system in place and we have a bit of a roadmap. It would always be great to welcome more volunteers to do a little bit or a lot. Dr. Soul, I think you were going to chime in and add to the discussion.
Yeah, these are really great points. And I think what we're saying really is that the system is overwhelmed. We're having troubles even communicating with the transplant centers to make our patients that are not primarily living in those transplant centers, to make them a priority to get transplanted. So there's just a lot going on. Plus now we've added COVID as a layer. And so I've had discussions with other hematologists in Hamilton and other places about how do we approach, streamlining, getting our patients on these, transplant lists or, gene therapy trials that are happening. And right now, it's mainly Toronto and Calgary and some of the major hospitals. So it's almost like a waiting list for the rest of the country to get our patients on those waiting lists. So I think there has to be, the advocacy organizations like the Thalassemia Foundation, but also the hospitals themselves have to organize themselves as healthcare workers. And, we in London are fighting to get funding for our nurses and social workers, and we might be getting there eventually, but system is stressed. And then the second point I wanted to make is, there's definitely sickle cell disease and thalassemia foundations are working together. I think the thalassemia patients have had so much more access to things that are scientifically studied. So we have 3 chelators and luspatercept, which is, obviously still not enough because we have curative therapies that they're not getting access to. And now, sickle cell disease only has access to hydroxyurea. So, this is why we might be hearing more buzz around pushing around sickle cell disease. But I think the strength there is that if we make these alliances like the Hemoglobinopathy Association that you're part of, Riyadh, is I think we can use the momentum of what's happening with sickle cell disease to push forward the thalassemia agenda as well. And I think it's great that there's need in both areas happening at the same time. But I really think the healthcare workers need to get together and talk about accessing resources that are really curative for the patients, which I think is what we're trying to do.
Yeah, we do need that collaboration.
Thank you. Dr. Pastor.
And
Just not to take, further time on that specific topic, because I wouldn't, take away important questions from all of you. But, first, collaboration should continue, right? And Ziad, I'd be happy to discuss this and facilitate how we can work with you in CAMHIM, even though I'm no longer in the executive. But I know the team there, and we'll be really happy to continue to work with you. My point is, my observation is when it comes to advocacy and policymakers, the most stronger voice are not medical experts, are a tiny part of it. What makes a difference is patients advocate and patients themselves go and discuss with policymakers, that is much more powerful, right? So as medical expert, I think our role is really to help you, and build up advocacy and potentially some documents, and help you the part of the expertise. But the power of your voice is much stronger, believe me, than our voice. And beyond the associations that do exist as SCDAC or sickle cell, there are also groups in Canada that regroups associations with rare disease. One of them, for example, is an RBDO, National Rare Blood Disorder Organization, right? There are organizations like this that you should approach and see if you could alleviate potential actions with them, through them, for rare and orphan diseases. That might help. It's a long-term effort. It will not click within 24 hours. It's clear, but the effort is worth pursuing.
I will tell you one of the, at least, from the trenches point of view, I'll tell you one of the biggest barriers at least from my point of view, in terms of why we have such difficulty bringing in new therapies into Canada. In addition to all the systematic barriers that everyone has mentioned, I think participation from patients is key. Because we have to remember that for a trial to succeed, the funders, the companies that are bringing the trials in, to Canada, they want to see that people are participating in trials. Because if people are not participating in trials, then they're going to say, well, you know what, there's no one in Canada, and they're not going to come to us. So the problem, I think, is universal. It's not just in, say, Calgary or in Vancouver or in Nova Scotia or Toronto. It's everywhere. I think it's important to not just be an observer, but an active participant in these clinical trials when the opportunity becomes available, so that we can demonstrate to the government that there is a population that we need. Because if you don't participate in clinical trials, then they're going to say, well, that means you're satisfied with the current treatment. And ergo, we do not need to fund you. We do not need to expand access. My 2 cents.
Thank you. I think message received.
Can I just add to that quickly, as a patient that's been on clinical trials? So I will say that I completely agree with Dr. Ko. I think it's really, really important that patients get involved in their own treatment, and that means getting involved in clinical trials. I know that from a patient perspective, it's daunting. It's definitely something that can be scary. It can be, you're not a doctor, and you don't really know what the trial is going to be like, and what the side effects are, and how it's going to affect your life and the way you do things. And that can definitely be something that's, hard to kind of get past. And for a lot of patients, I think that's, completely valid. But at the same time, again, I say, like, you kind of have to look at the big picture. You have to look at not what's in front of you, but what's going to happen 10 to 15 years down the road. And for me personally, like, I mean, I've been lucky. I've been involved with clinical trials since I was like in my early 20s, late teens. And what it comes down to is, again, having conversations with your healthcare professionals, having conversations with your hematologist, your nurse practitioners, your social workers, if you have them, airing your concerns and asking questions. And don't feel like your questions are stupid or silly or you're going to be judged or whatever. They're there to help. That's their job. They're supposed to help, and they're supposed to take care of you, and they're supposed to be able to provide you with the best possible treatment plan and management plan possible. So if you are worried or scared or considering starting a clinical trial, have a conversation with, your doctors, but also your family members, and see, if you can get support from them in terms of like helping you alleviate your anxieties or your stress, or taking you to your appointments and whatnot. It takes a village. It really does, when managing chronic conditions. It's really important to have that support system. So I would say, don't hold back because you're worried or you're anxious or you're scared, but have communicate with your healthcare professional, communicate with your family members, communicate with your friends, and really, get a good understanding of what's available to you in terms of a clinical trial, and what it could do for you, and pick the ones that work for your lifestyle. Pick the ones that you think are going to be helpful to you, whether it's a chelator or a gene therapy, or a like a luspatercept, a hemoglobin therapy. That's what I would suggest to any patient who is on the fence about getting involved with the clinical trial. Sorry, very long.
Great. Thank you. Thank you. I'm glad this is virtual because, Kayvan, I assume that your hand hasn't been up the whole time. So thanks for the patience. And would you like to ask your question now?
Yes, I would, Josie. Thanks very much. I have a question, actually. Again, I want to raise this question to Dr. Kuo, but maybe Riyadh can weigh in on this as well. It's in regards and concerns to the, actually, it's on a provincial matter. The Ministry of Health and Long-Term Care in the province of Ontario here, the whole thing about the deductibles and the drug reimbursement plans, covering the combination drug therapies. Obviously, some patients had been on it, and for some reason, I know in my case, they could only cover one or the other. They couldn't cover both. So with Trillium, is always a bit of a challenge. Have there been any possibilities of maybe putting more pressure on the provincial government to maybe bring the possibility of combination drug treatment therapy back in any way to the program, or what is the current state of that?
Dr. Kuo, or should I just throw it right to Riyadh?
I actually, please, if Riyadh can help with this question, because I mean, I have my handfuls of research already. I actually don't know the state of the
No, this is
coverage.
this is a very important question, very good question, and thanks, Kayvan, for asking that. What it is sometimes I think we feel we're in the illusion, we're in the perfect healthcare system, or we are in a Canadian universal healthcare system where everything is covered. But that's not true. You have your dentist, that's not dental, care is not covered. You have physiotherapy, you have your mental health sometimes is not covered. A lot of things that are not covered. Unfortunately, that's how the system works, and how it has worked and it's been done is things are covered in patches. So they give you Band-Aid for this, Band-Aid for that, and it also comes out in silos. Different systems cover different parts of your treatment. For example, sub-Q sets for Desferal are not covered in every hospital or for every patient across Ontario. Recently, even the Jade New X Jade brand name will not be covered. So these are things that we have to deal with. We are trying to work on that. Unfortunately, governments are in the business of trying to save money and doing budget cuts, which puts a burden on the patients, but it's a bigger burden on the doctors, because the doctors will have to file all these exception access forms and those paperwork, which is tons of paperwork. I'd rather see the doctor looking after the patient, sitting down talking to the patient, than doing this paperwork, or the nurse practitioner, whoever may be doing that. So it is tough. What's important is the patients to make voice. Talk to your MPPs about that. Come and talk to me. I want to know what you're going through. Dr. Kuo wants to know what's going through, but doesn't stop here. You should also go and talk to your MPP. The louder the voice, the squeaky wheel gets the grease. If we make noise, we get the attention. If you come and talk to me, or you go and yell at the hospital administration, that gets you nowhere. And that's actually counterproductive. And we've gone through many processes. We've been advocating for over 25 years. We started advocating for blood safety. We are still advocating for blood safety, believe it or not, 25 years after. We are part of the NRBDO. We were part of the actually groups who created the NRBDO, one of the founding members. We are, from collaboration with Canadian Organization for Rare Disorders. We don't work closely with the sickle cell communities across Canada. We're trying to work on care in Halifax and here in Ontario for various centers. We are doing what we can, but as a patient organization, we need the support from the community. The community needs to make the noise. MPPs, decision makers, listen to the voters. If you can vote, you can talk, you can say whatever you want. Look at the truck drivers, what they have done. If we could do something similar to that, not to that extent, but something similar. And believe it or not, Desferal was advocated for by a patient, a parent of a patient. I give that one to the Greeks because they're the ones who are fighting that one. And they actually, went and sat down at the hospital and at the parliament, and they, made some noise to get Desferal, which is
to the papers. Yeah.
And we advocated for all the drugs that you have access for. We have filed the submissions with Health Canada. We advocated for the reimbursement. Sometimes governments don't listen to us. The stronger the voice, the better. So I call on everybody to make the noise, call on your MPs and MPPs and let them know what is going on.
Okay,
And
thank you,
come
Riyad.
and attend, TFC events. That's when we can discuss things. Thank you.
Thank you. I am going to, I see a question from Bessie in the chat. Sharon, I don't know if there are others that I've missed. Bessie, would you like to ask your question?
Sure. Well, first I made a comment and I'd like to repeat it, which is to thank all the healthcare providers that are on this call for really going above and beyond for patients like us and our community, especially with everything that has been going on for the past 2 years. An example is tonight, I'm sure, you could be having dinner with your families and, doing other things. So we appreciate your time. I guess my question is really just around, the criteria for approaching patients with these new research activities. So it's, I think Helen even made a comment earlier in the chat around like, how do patients find out about it? Just recently, I was in clinic and we see sometimes like, research staff will approach some patients potentially with new research and others are like, well, what's that all about, right? So I think it would be helpful if patients understood, okay, when you have a new research, maybe there's some filtering that the team does to say, okay, here's people who would meet the criteria for that research or who would most likely benefit from that particular research. And so people don't feel maybe that they're just left out and not being approached. So maybe you could share here on this call what the criteria is when you are going and reaching out to patients for participation and what might be some of the examples that might preclude someone. I think it's about communication and transparency because I have had some people come to me and say, well, why did so-and-so get approached about that study, but I didn't, right? So thinking maybe it might be helpful if somebody could just very high level explain what the process looks like.
Dr. Ko.
Sure, yeah. So in any clinical trial, there's what we call inclusion-exclusion criteria. And the purpose of these criteria is to ensure safety, because often there's certain characteristics of a particular drug where, say, if you have kidney issues or if you have diabetes or if there's liver issues, then it's essentially contraindicated. It won't be safe for you to be on that new drug. So safety is one. Second of all is when with studies, they often focus on one particular group of patients. So for example, either transfusion dependent or non-transfusion dependent, or maybe the alpha thalassemia patients, like for example, in mitapivat that we talked about. And so as clinicians, we often know already what these criteria are. And these criteria are very transparent. You can actually look them up at clinicaltrials.gov. And because we already have that sort of mental sieve, you can think about it, that filter in our mind. So we often will offer clinical trials to those we feel that can gain the most benefit from the study and where the risk is the lowest. Not to say the risk is zero, but we always try to minimize the risk as much as possible because we want you as patients to have the maximal gain with the lowest possible risks. So that could be the reason. I usually, and then different clinicians take a different approach. Some clinicians are very selective. They actually look at the criteria very carefully and then to select the patients based on that. I'm sure you have seen what I've done, Bessie, in the transfusion unit. I just basically yell out what the study is to everybody, and whoever wants to join, just let me know, and then we do the selection later on. So that tends to be my approach, because I also see it as an education opportunity
Yeah.
for our patients, just to
Thank
learn
you.
about the
Thank
study.
you for that. And absolutely, I just think, the majority of our patients, not the majority, but at least half, probably, maybe more, would not go to clinicaltrials.gov and look at the research and the inclusion and exclusion criteria. So, maybe it's helpful for something to be, offered to all patients to say, here are the trials that are going on, and if you're in, I don't know, just something to make people, especially if you guys are saying one of the challenges is getting people to participate in these trials, and making feel, maybe helping people understand why they may not have been approached about a particular trial, so they understand it's for their own good and for their own safety, is maybe some feedback.
Yeah, and I'll just give you some perspective from London. We're two hours drive from Toronto, and that's where all the studies are, right? We only have one sickle cell disease trial potentially opening later this year, but I also take into consideration the patient's circumstances. Can they drive? Can they commit to the studies? They have to go to appointments every 2 to 4 weeks, sometimes, etc. So I will usually mention a trial, and if the patient jumps and says yes, then we'll talk further. But if they say no, it's too much work or too inaccessible really for me, then we'll kind of move on to other options. But that's an added access issue for patients that don't live in the GTA or in Calgary or places where the trials are happening. And this is why we are trying to open smaller trials in London, but we have to be very selective to make sure that the company doesn't want 100 patients. We can't provide 100 patients here, but we've been successful in certain studies. And again, it's a lot of the sickle cell disease companies that are approaching us. We haven't had any from the thalassemia drug manufacturing companies yet.
Thank you for sharing.
Dr. Pastor.
Yeah, basically, I think your remark is absolutely right. I mean, I think, we have to recognize that we're not always good at, sharing new studies between centers. So I think we have to become better at doing it, right? So we try to work hard to improve that, and making sure that when a study is open, or that either through foundation like Thalassemia Foundation or CanHIM or SCDAC or at the pediatric side, through an organization that regroups all of our pediatric centers, which is C17, that we share this information. So first, that's the sharing. And honestly, I think you're right that we have to do better, right? The second thing is that, and I'm not going to repeat what Kevin said, but there's all these inclusion exclusion criteria. And sometimes what we do is that there is a study that is open. Sometimes we put some flyers or poster in the clinic saying that, well, this study is open, you might be eligible. Talk to your physician or your team about this. We not always do make those posters or share those posters, particularly if we know upfront that a study might, if in our patient group, we might be able to recruit maybe only 2 patients over a 3 or 4 year period. We don't want to also bring false hope. There's this other part. So I think that, yes, definitely we need to improve the quality of communication, the sharing, and to be more transparent of what's going on. I really agree about that. But if you hear about something, talk to your physician, right? If you heard about a study and say, okay, well, I heard about this new medication, or I heard that this study might be open at your place. It's something I might be eligible for, right? Don't be shy. They're asking the questions, right? Okay.
No, thank you. Trust me, I'm not shy.
I bet you.
But there were some folks around that were asking the questions, and so I thought others might have similar questions around the
Right.
process. So
it's a very important question.
Yeah. Thank you.
Thank you. Dr. Cole, your hand is up, and I see that we are a little over time, but
It's
please
okay.
go ahead.
I mean, it's just a comment about working with the TFC to create a more proactive approach at presenting and disseminating trial information. And one of the barriers I've encountered, at least when trying to disseminate information, is that we're limited in terms of we can't, just to be frank, we can't mass email you guys about new trials. We're not allowed to, like as an institution. This is against our institution's policy. I personally disagree with that policy. But that's just how things are. And because we can't do that, it's very inefficient for us to I'd love to be able to spend time with everyone in the clinic, right, at each transfusion visit to talk about the trials, but it's simply not possible. So that's why I always do that shout out thing to like the entire group in the transfusion unit. And even then, I'm sure I missed a couple of people. But if we can work with, say, if TFC can work with, say, the hospitals or with maybe even Health Canada to come up with a new process in which we can approach our patients, I think that will make clinical trial recruitment much more feasible and much more enjoyable on both sides.
Excellent. I'm seeing plenty of thank yous and kudos to our speakers, our panelists. I am going to throw it to Riyadh for, I assume, the goodbye. Or did you have a question, Riyadh?
No, I just wanted to say something in addition to what Dr. Ko was saying, which doctors cannot really email patients to recruit. And us as a foundation, we cannot recruit patients, but I feel it is our duty as well to let the patient community know about the trials and the studies that are happening in Canada and beyond, which we are trying to do, and we work on that. But we also need to be aware of what's happening. We know what's happening in Toronto because the majority of us are in Toronto, but what's happening in other places we don't know, and what's the collaboration is like. And sometimes we're afraid to talk about something that's happening in Toronto that's not available in other places. That's going to create a bit of a problem for those patients. Even access to treatment. I mean, Ferris scan is still not accessible in every hospital across Canada, which I see as a major concern. Now, I could go on, but I want to say that this is something that we're going to take away from this, in addition to all the discussions we had, and we're listening to the patients, we're listening to the medical community. We really appreciate all the work that they do, and many times I feel we are very, very lucky to have the doctors that we have in Canada and that keep coming into the thalassemia and sickle cell world. I could name many of them, and all of you are awesome. So thank you very much for tonight. It's exciting and it's good discussion, and I hope we'll do many more. I'll let Bessie do the final remarks and the goodbyes. She's better at it than me. Thank you, everyone.
Okay, Ria, thanks for putting me on the spot. So no, I'm not going to, I know we're over time. So again, just I think it was really important for us to hear today about the different clinical trials that are underway and the different new and enhanced treatments that we could have available. We have available to us and could soon have available to us with maybe some greater ease of access to some of them. I, like Riyadh said, I think it's really important for us to keep these dialogues open. It's really important for us patients to hear from the healthcare providers what they're doing and what your challenges are. And I'm sure it's equally beneficial to you to hear what is concerning your patients in general and what types of questions they have. So this open dialogue, we appreciate having these types of sessions. Kevin, maybe it's a good thing that that your not a good thing your basement was flooded, but that we didn't get you for such a short time during our big, our big conference, and we had this more in-depth discussion today. So, and to all the others who joined as well, to share their thoughts and what's happening in their centers. We appreciate it. So from a patient perspective, I will echo Josie's comments, and I think we heard on this call, it's really important that we all advocate for ourselves and for each other. And we can do that best as a community and, not as individual voices, but as shared voices. So if you have things that you think you can contribute to the foundation, or even just, individual activities you'd like to participate in, Riyadh, myself, Shireen on the call, Josie, Helen, Ali, a whole bunch of us, Varish, I think, reach out to any of us, and we'd be happy to have the conversation. So thank you everyone for your time.
Thank you,
Josie,
Bessie.
anything from you?
No, thank you, everyone. It was great to see so many folks on the screen. I see some familiar faces, and I just want to send you my greetings, and I miss a lot of you. So thank you, everybody. This concludes our session. Goodbye.
Thank you.
Thank you. We good, Riyadh? You're on mute.
Still on mute.
Yeah.
I'm cutting and pasting all the things in the chat so we can have a record of it.
Okay. Well, it was lovely, and I wish I had thanked the doctors once more.
Thank you. No, everyone, this is great because it really worked out very well, and I'm happy we had the doctors we had, and the participation that we had was.
It's lovely.
Thank you, Sherry and Josie, Bessie,
No
everyone
problem.
on this from the board. And we had a lot of people from the healthcare providers, pharmaceuticals, everybody. So
and I got I've got some private messages from people interested in volunteering. So
excellent.
I created a list on the drive that we have. So excellent. I'll add those to the list, and then we can talk about how we can get them involved.
Sure, we can talk soon.
Okay. Bye, guys. Have a good night.
Bye.
Bye. All right, guys, I'm out. Bye.
Adios.
Bye, everyone.
Bye.